Hello everyone, my name is Celso Arango. I'm a psychiatrist from Spain, and I'm really happy to be virtually with all of you. I would have loved to be in Bucharest and have the opportunity to be physically mingle with all of you. That it has not been possible for obvious reasons, but at least I'm going to be able to give a talk, and I will also have the opportunity to in live do with you a Q&A session. I'm going to be talking about prevention in psychiatry, mostly with prevention related to psychosis. On a personal note, I will share with you that when I finished my residency, I became interested in schizophrenia. And at that time, I really did research in very severe patients that had chronic conditions. I was interested in the deficit syndrome, patients with primary enduring negative symptoms. After some time, I became interested in first episode psychosis. And I've done quite a lot of research with large cohorts of patients, mostly children and adolescents with the first psychotic episode. Then I developed an interest, and as you can see, I'm moving, backwards. Chronic patients, first episode. Then I became interested in patients with clinical high risk, patients that are at higher risk than the population to become psychotic and to have schizophrenia or any other mental disorder. And finally, my area of interest now is primary prevention, believe it or not. And actually, I have run many clinical trials. The last clinical trial I have run has been a clinical trial with in schools with children and adolescents that suffer bullying and therefore have an increased risk to develop mental disorders in the future. So it disappeared, right? Let's see. Okay, so let's move from my slide. So I'm not going to be talking much about psychiatric medication, but I need to disclose my conflict of interest that you can see in this slide. And this is the outline of the next, for the next 40 minutes, what I will be talking about. First, prevention psychiatry and towards specific periods that happen very early in life. By very early, I mean even before conception, right? Or during pregnancy, or at birth, or early after birth. And I'll give you some specific examples for which we have evidence that we have preventative measures, preventative interventions that work, and in many cases that have been to be cost effective. And I'll give you what could be the consequences if we were able to put in place those interventions. And then I will just wrap up with a summary of what I believe is going to be the future of our specialty. So if you have to leave this video conference right now because you have other things to do, just take the home message first and keep it and take it with you. And what I would be talking is that what Frederick Douglass mentioned for different purposes, but it really fits the purpose of this talk, that it's easier to build strong children than to repair broken men. And this really puts the focus on something that we have neglected in our field for decades. So for a long time, we have been focusing on primary and mostly tertiary prevention. So when things go wrong, we have the patients admitted in long-term hospitals. When things go wrong, we have the patients admitted in acute hospitals. We have them in day hospitals. But it's only when things really go wrong and medications don't work and they have relapses and so on. We have not had the interest that many of our colleagues in medicine had in the recent past in primary or secondary prevention. I'll give you some examples about this. So we know in medicine that prevention is most cost effective. So the energy, the economic burden, the amount of effort that we have to put in prevention is much less than in cure. And unfortunately enough, many psychiatric conditions are chronic conditions, and public health systems like the one we have in most European countries, if not all of them, cannot survive treating chronic conditions in the way we are treating them, right? The cost of beds in hospitals is extremely high. It's higher than the best 5-star hotel that you can imagine. So we need to invest in prevention. Otherwise, we will not be able to sustain the public health systems that we have. So I mentioned that prevention is very common and has been very popular in other areas of medicine. You can choose any good journal. Like this is New England Journal of Medicine. You can go to the Lancet, you can go to British Medical Journal, and so on. And just take the last issue. You will see that there are at least 1 or 2 prevention papers, right? Can we prevent diabetes? Can we prevent heart attack? Can we prevent rheumatoid arthritis? Can we prevent pancreatic cancer? Can we? Of course we can, because we know many of the risk factors, and intervening in those risk factors will decrease the incidence of those conditions, right? So this is a clinical trial showing that we can reduce the incidence of diabetes. And again, there are many clinical trials out there showing evidence that we can prevent many medical conditions. So this is interesting data. So what you have here is separated for men and women, the number of deaths in the United States, and you see that in the blue line for men and here for women, and with the red line. So the difference between the red line and the blue line is the number of people who did not die, so who survived because they didn't die from cancer because some primary prevention interventions were put in place. So this is a really core, really hard outcome. This is deaths. And this is the number of deaths that went prevented because of preventative interventions in oncology, right? So pretty strong message, right? Number of people that didn't die. And every year you see that that number increases because there are more preventative measures. And again, this is data, yearly data by men and women in the United States. So again, is it the case that we can prevent medical conditions? Yes. Is it the case that we can prevent mental disorders, that we can prevent psychiatric illnesses? Well, let's see what the data shows. But at least what we know is that the interest in prevention is much lower than in other areas. So this is the number of, if you do a PubMed search, number of thousands and thousands, hundreds of thousands of papers on prevention and cardiovascular disease. Pretty much smaller number for prevention and psychiatry, prevention depression, or prevention and psychosis. So there have been a number of papers out there showing us that it is very difficult to put in place preventative interventions if we don't look for what we have to look. So this is a paper in JAMA saying that only 21% of all infants and toddlers were assessed in a standardized way for developmental delays. So this is the United States. And in the United States, only 1 in 5 children or toddlers are assessed for a delay in milestones. If we don't assess, in standardized ways for these delays, then we will not be able to make diagnoses such as ASD, autism spectrum disorder. And if we don't make those diagnoses, we will not make the interventions. And if we don't make the interventions, and as I'm going to show you in a few slides, then we will be missing a therapeutic window that opens and closes, and that there was not going to be another time in life in which we can do what we need to do. Research is the same. So the amount of money that goes into research into prevention is much smaller. So this is data from one of the largest charities in the UK. Only 4 to 5% of all the money invested in mental health research goes into prevention, as compared to 37% on underpinning biological research, 29% in theology, 15% evaluation of treatments, and so on. So anything that happens in life has a good reason, right? Things don't happen at random or chance, right? We're medical doctors, so we have to believe that things always happen for some reason. There is some causality in what happens in life. So what would be good, two good reasons that we don't pay enough attention into prevention in psychiatry? Well, one is that it may not be possible, or it may not be possible to a large extent, as we have shown in cardiovascular disorders, oncology disorders, diabetes, endocrinology disorders, and so on. And the second one is, yes, it is possible, but it's too expensive. So the politicians, the health administrations don't invest in this area, and they prefer to invest in a different area. So we're scientists, so what we have to do is to refute the null hypothesis, and we need to see if if the null hypothesis is wrong, then this will be this may be true. Well, this is a case for prevention in psychosis. So we have just published a paper. This was published a few months ago in JAMA Psychiatry by a large group of researchers in the area. And what this paper shows in a systematic review and meta-analysis is that yes, we can prevent psychosis. In order to do that, we need to improve detection, we need to improve intervention in those cases, and then that will improve the diagnosis and cases that end up making the transition into psychosis. This was published a few months ago, but this is something new that we know for the first time ever? Well, no, not at all. This paper, and I bring this here on purpose because it's very old, this is 1997, show us that the mean effect, so the effect size that we have for some school-based parent training, transition programs, preventative interventions, those effect sizes are not smaller than the effect size that we have for, I don't know, the treatment of depression with fluoxetine, or the treatment for schizophrenia with an antipsychotic, right? So we have known for a long time that we have quite powerful interventions to reduce the incidence of many mental conditions, and that's primary prevention. So we have the same data for secondary prevention. So if we have, for instance, a child with conduct disorder, with ADHD, with attention deficit hyperactivity, and we don't intervene, we don't give that child stimulant or psychosocial intervention, or even better, a combination of both, chances that that child is going to develop secondary mental disorder like substance abuse or antisocial personality disorder and so on are 2 times as compared if we intervene. So that's a really good example of secondary prevention, and again, very powerful. So we decrease by 50% the chance that this kid is going to develop another major mental disorder in the future, even during adulthood. So we have good data that we can do primary and secondary prevention in mental health. And again, these were only a very few examples of a large amount of evidence that is published out there. Well, if that is not the case, then let's go for the second hypothesis. We can do it, but it's too expensive. Well, this is what our colleagues from the London School of Economics, LSE in London, show us. And again, this is extremely powerful data, because this is exactly the data that we need to show to our politicians, to our health administrators, those who are managers of mental health or health in general. So these are really good examples of how early detection of psychosis, by every pound we invest, we get 10 pounds back. So it doesn't happen immediately, it takes time, but if this is a really major investment, right? You put in 1 pound, you get 10 back, because there are many expenses that you save. For early disease detection, for early intervention in psychosis, of course, is even larger, 17.97, so 18 pounds back. I mean, for suicide training for GPs is 43 pounds back for each pound that you invest in these trainings for GPs. And you have even larger amounts, like 83 pounds back for each pound invested in prevention of conduct disorders through social and emotional learning programs in schools. What this tells us is that the earlier intervention probably the most cost effective is going to be, because there's a window in which any intervention is more efficacious, so more cost effective in the long term, and B, because there is more time to show that efficacy than it happens with adult population. So again, I mentioned that if things happen in life, there's always a good reason for which they happen. And if we can do prevention in mental health and we can save money in mental health and we're not doing it, there must be a good reason for it. Well, one good reason is that this is a really good study that took place in the United States with people that were really came from very unstructured families. They were at very high risk, really poor population. And there was a nurse home visitation program. And so there were some investments in the first 2 years. Then the intervention stopped. So you can see there's a flat line here. So there were no further cumulative costs. And then after that intervention, then you started to see the effects of the intervention. So one of the things that happen in mental health is that any type of prevention takes a lot of time, like years, to show its effectiveness. And that's a very good reason. I'll show you why, for being less politically attractive, less sexy for these people that manage the funds for health in general. So it's obvious that we have not followed the good advice of these wise men who lived in early 17th century, Don Juan de Palafox y Mendoza, that said that kingdoms that govern with remedies rather than prevention are headed for a disaster. Another important message that I want to convey to you today is the message of therapeutic windows. We know that if you smoke, that increases your chances to have lung cancer. That's very well known. So these are the cigarette smokers in blue and the red, the non-smokers in red. So those who smoke have higher chance to or less survival because they die earlier, right? If you stop smoking very early, then you may catch up with the line of those who never smoke. If you stop smoking later in life, you will reduce the risk of developing cancer, but it will always be increased as compared to those who never smoke. So this is a really wide therapeutic window. So we are here talking about decades, right? This is 23 to 34, 45 to 54. There are other therapeutic windows that are just a matter of hours. So this is reperfusion therapy in those that have a myocardial infarction. And if you administer this therapy 10 hours after the MI, then it doesn't increase much the survival. If you do it 2 hours after the MI, the reduction of mortality is 80%, right? A few hours later, 2 hours later, it goes from 80 to 40. So it is a dramatic decrease in hours. That's a really good example of another therapeutic window that it doesn't take decades, but takes just a few hours. I can give you many, many examples that apply to mental health and psychiatry. For instance, when we are born, we have the Hill test to test for thyroid hormone, because what we used to call cretinism, right, this congenital hypothyroidism, if it is detected right after birth, and you administer thyroid hormone, then there's no damage to the brain, and you don't develop intellectual disability, you don't develop many mental disorders that you see in patients in newborns that they were not treated. What happens if you don't detect it in the first weeks? It doesn't matter how much thyroid hormone you give after 2 or 3 months, all the damage is done, right? So that's a therapeutic window that affects intellectual disability and other mental conditions that it takes a few weeks. So again, I can give you many examples. Something which is important and that we know now is that the vast majority of mental disorders start in adulthood, right? And by age 14, 16, right, like 50% of all mental disorders have had some symptoms. Maybe not full enough to make the diagnosis, but they have shown symptoms. If you go out to the age of 24, that goes up to 75%. So 3 out of 4 mental disorders start below the age of 24. And it's extremely difficult to see a mood disorder, someone with major depression. It's extremely difficult to see someone with anxiety. It's very difficult to see someone with schizophrenia that did not have some symptoms in childhood or adolescence. So if we're talking about primary or secondary prevention, but mostly even primary, then we really need to move backwards. And that's because most of the action in our brain takes place in the first few months, and even in the months before birth, right? Like this cell proliferation happens almost everything inside our mother's uterus. And when it comes to progenitors and immature, maturation of those cell proliferation, and again, it happens in the first 1 year, 2 years of life. Then there is this synapse development in childhood, and it continues into adolescence and myelination and so on. But most of this action happens before adulthood, and even mostly during pregnancy, before birth, and in early infancy and early childhood. That's why one of our colleagues, Mara Parellada, and from our research group, published this very thought-provoking editorial on why psychogeriatrics starts right after adolescence. So why, after adolescence, there is no much room for improvement, and most of the things you can do should be included in tertiary prevention. Going back to the notion of therapeutic window, this is a really nice study. This again is a very old study that shows that the same intervention with the same therapist, with people that, or children that have the same severity, and this in this case is autism, we have two groups. The only thing that differs group 1 from group 2, the only thing that makes them different is that group 1, children were younger, so they were younger than 60 months of age at the time of the intervention. Group 2, group B, they were older. They were 60 months or later. So overall, the achieved positive treatment outcome was close to 40%, and that was the overall. But if we differentiate younger versus elder, is 67 versus 11%. So it's a huge difference. So in a time, and this was 1985. Now we all talk about personalized medicine, individualized medicine, precision medicine. This is precision medicine. This is, can we predict who is going to respond and who is most likely not to respond to this treatment? Yes, we can. And this is just, in this example, based on age. We don't need any biological marker. We just need to know how old is this person, and we will be very likely to predict who is going to respond and who is not going to respond. And again, this is a good example of therapeutic windows that open and close. So do we follow the evidence? No, we don't follow the evidence. And this is one of the papers among many others in which we show that in Spain, as it happens in many other European countries, despite this evidence, we don't have specific programs to intervene with people who are at high risk to develop psychosis or who have a first psychotic episode. And this is probably because, as I mentioned, we for a long time we have focused our focus has been wrongly put into those that were too chronic, too old. This is a picture I took myself with my iPhone when I was in San Francisco. I spent a sabbatical at UCSF, and I continue to go there every year. I hope that we are able to fly we're able to fly in the near future. So I took this picture because I really, this signal reflects very well how wrong we are in not putting the focus on those who are younger. So that was the first point. Let's move into the second one. So in which I'm going to try to give you some examples. An interesting thing that paradigm that has changed in the near future has been when I studied psychiatry. We used to have silos, right? This was the gene. This was the risk factor for a DSM-3 at that time or ICD-9 disorder, and you name it, schizophrenia, bipolar disorder, depression, right? We have specific risk factors for specific disorders. That is not the case anymore. And the huge amount of evidence and publications out there, and we have a few of them from our group in Madrid. This is a slide from Pat McGorry and his group in Australia, show us that the same that happens in oncology, the same that happens in cardiovascular disorders, there is a pluripotentiality. We are born with brains that have, quote, better or worse quality. Brains that are better wired, better tuned to cope with environmental stressors, with interactions and epigenetics between our DNA and those risk factors that happen in the, as epiphenomenons in the environment. And we may end up having disorder A, B, or C, with severity A, B, or C, depending on that interaction and the things that happen in life, not only risk factors, but resilience factors. And again, not only the risk genes, but also protective genes and the epiphenomena of gene by environment interactions. So we have moved from specific silos into risks that are common to many, many mental disorders. And nowadays, no one talks about the risk, the gene or polymorphisms or CNVs in other like common or rare variants for schizophrenia or for major depression, right? These are genes that code for proteins that are involved in the central nervous system development, and actually 80% of all genes of the 25,000 genes that we have are expressed in the brain, right? Or have to do with something with neurodevelopment. That's for a good reason. And again, the brain develops in a way that is more likely to have one disorder or the other, depending on that interaction. And that has been shown, again, from genetic studies. This is a paper published in Lancet, in which the genetic risks were similar for autism, ADHD, bipolar, major depression, and schizophrenia. We know that, again, focusing on psychotic disorders, that's my area of interest. We know that psychopathology in offsprings of patients with schizophrenia is not that there is an elevated risk for schizophrenia only, but if you are an offspring, and we have a very large cohort of offsprings of patients with bipolar disorder and schizophrenia in my hospital and hospitals in Spain, like in a hospital clinic in Barcelona, we know that the increased risk is for any mental disorder. So offsprings of people with schizophrenia have increased risk for suicidality, depression, anxiety disorder, or eating disorders. We know that some of these risk factors, like low IQ or very high IQ, are increased risk factors for schizophrenia, but also for severe depression, and to a lesser extent for bipolar disorder type 1 with psychotic features. Risk of schizophrenia increases in anyone who has any mental disorder. So if during my childhood I have ADHD or autism, or even eating disorders that conceptually are really far away from schizophrenia, I am more likely than the general population by a factor of 5 or 4 or 3 or 2. So really, really very high increase to develop schizophrenia in the future. So again, these are the evidence that supports this magma, right? These unspecific risk factors to develop schizophrenia in the future. If you're interested in a really passionate world, which is the world of people at high risk to develop psychosis, the people that don't read the small letter, right, the methodology, what you really need to read, believe that this is a categorical world in which you are at high risk, and then there are two outcomes, right? Outcome A, you develop schizophrenia. Outcome B, you don't develop schizophrenia and you're healthy. That is completely wrong, absolutely wrong. What happens in reality is that if you're at really clinical high risk to develop psychosis, in the long term, if you don't develop psychosis, if you don't have schizophrenia, you're very likely to have another disorder. So these people, to start with, they already have depression, they already have anxiety. But even if they don't have it, and you can see the percentages here, right? Even if you don't have it, the percentage of people that will end up with at least one mental disorder is 90%. So we may prevent schizophrenia, but then they develop something else. And what this tells us is that if the question is very simple, do I believe that in the future we're going to have specific intervention for schizophrenia? The answer is no. The answer is no. We can reduce the incidence of schizophrenia, but by doing that, we will also reduce the incidence of many other mental disorders, because there's many of these risk factors that are shared among these DSM or ICD mental disorders. So I hope this is clear. So if we want to prevent psychosis, again, I'm talking about primary prevention, reduction of the incidence. When do we have to intervene? Very early in life. And this is another paper published in JAMA by Tom Insel, who used to be the director of the NIMH. Mentioned that we should shift the focus from behavioral symptoms, right? The DSM, you need to fulfill 3 out of these 7 criteria or 5, right? And those are behavioral symptoms, to neurodevelopmental trajectories. And that's where the etiology can, and that's what can be make a categorical difference, because if we change those neurodevelopmental trajectories, then we will be changing the course of the disorder. And by treating symptoms with drugs or psychotherapy, most likely we're not going to change the course of the disorder. We're going to improve quality of life, we're going to reduce the psychopathology, but we're not going to change the course of the disorder. So let me now, in the next 10-15 minutes, share with you some examples from the literature of something that we know we can change, and which is a risk factor to develop psychosis or schizophrenia or some other major mental disorder. Some people believe that we cannot do primary prevention unless there is a human being, right? Or even a fetus. Well, we can do primary prevention before conception. And how stressed mothers are before they become pregnant is something that we have known for a while, that can reduce the risk of many disorders in the long term. I mean, long term, I mean in the next 30 or 40 years after giving birth. So maternal stress, delayed parenthood. So how old are your parents? Mostly more important, even your father, when the person is conceived, has again profound implications. And the reason for this is, some people talk about mutations. Spermatozoids in the testes are exposed to more radiation and so on. Some new that may increase, may explain the increase in the incidence of disorders of ASD in the recent past. That's probably not the only reason. There may be other good reasons, but there's some studies out there showing that the older the mother, and most importantly, the older the father, the more likely they're going to have a neurodevelopmental disorder. But it's not only the mother who, if she is stressed before pregnancy, increases the risk of mental disorder in the future. It's also the father. And there's a really nice animal model with rats, in which the parents, not mothers, the parents were exposed to stress. And not only one generation, but 3 generations later, you could see some behavioral changes in the offsprings 3 generations later. There's some really good studies out there now showing that cannabis in mothers and fathers before conception can have an influence in the behavior in animal models and in humans many years later, and in a few generations after the first offspring is born. So really passionate studies out there showing that very early in life we can do a prevention. So these are some studies about parental age. Childhood poverty. So the poorer you are, the more likely you're going to have cognitive problems, intellectual disability. So this is a study showing a nice correlation with effect size very large between socioeconomical status and language, working memory, cognitive control, and memory. Well, you can think, okay, fine, but what can we do, right? You're lucky you're born in a wealthy family. You're lucky you're born in a rich country. You're lucky, and there's nothing much you can change. We can do about changing how wealthy one family is or how wealthy one country is. Well, that's wrong. That's wrong. So this is a very good study, very interesting, published in Lancet some years ago. So in this study, families that were identified because they had very low socioeconomic status were given a small amount of money on the premise that that money had to be spent on interventions that were known to improve the outcome of the offspring. So those families that took the money and followed the instructions had children with lower prevalence of stunting, lower body mass index, lower prevalence of being overweight, and did better on motor development, cognitive development, and receptive language. When the economical study was done, all these positive outcomes overweighed the amount of money that that family have been given. So that's the definition of investment. You give a little bit of money and you get people who have more productive lives and who increase the wealthiness of that population, of that country. So that's, again, a really nice example of investment in more healthy people and people that are more productive to the population. Pregnancy, good examples from smoking or alcohol, how smoking during pregnancy, alcohol during pregnancy increases risk for psychotic symptoms decades later. And that's, again, primary prevention. Vitamin D supplementation. So these are really nice cohort from northern European countries, showing, for instance, in Finland, as compared to the reference, those who were given regularly vitamin D supplementation during pregnancy had a much lower risk to develop schizophrenia 20 or 30 years later. Birth and perinatal period. So can we do anything to prevent? Well, yes, first we know that those who have hypoxia during pregnancy are more likely to develop psychotic symptoms. And can we prevent that, or can we have more healthy deliveries? I always say that people, the best preventative professionals for mental health disorders are not psychiatrists or psychologists, are neonatologists and obstetricians, guys, people, medical doctors that do obs and gynae, and that and again, that's for the reason I gave you before. Preterm children are at higher risk to develop schizophrenia, psychosis, and of course any ADHD, any neurodevelopmental disorders, including ASD, intellectual disability, or ADHD. So there's a very high price that we pay to have these very, very low birth newborns, like 500 grams, 600, 700 grams, really very low weight. And 60, 70, 80% of them will end up having a mental disorder. So this is, this preterm of low birth weight is a potent predictor of mental disorder. Can we prevent obstetric outcomes, obstetric complications? Yes, we can. And specifically in a very high risk population, like this is mothers who have a severe mental illness, mothers who become pregnant and have schizophrenia or bipolar disorder. This is a vicious circle because they are high risk to not taking good care during pregnancy. They are high risk to have children that have the bad genes to develop those psychoses, and they are high risk to have deliveries that are complicated. So this is a specific population, and we should have programs to improve the healthcare during pregnancy and the healthcare during the delivery. Toddlerhood and preschool, well, I don't need to tell you that the abuse or neglect has effects in the brain and effects that you can see with a single CT scan. So this is a CT scan of a 3-year-old children, normal, that did not suffer from a neglect. And this is the same age children that suffer extreme neglect. So these children, no one took care of him or her, or he was abused. And this is something that you can see on a CT scan, and you don't need anything else. We can intervene in schools, and I mentioned before how the poverty predicts problems with cognitive impairment, but is that fixed based on how poor you are or your genes? No. The IQ is plastic, it's modifiable, especially in the first years of life. This is a paper published in Science showing that preschool programs increase executive functioning significantly as compared to doing nothing, right? In not applying these programs in schools. And these are not very costly interventions that, again, are cost effective. Interventions in schools very early in life can have, and this again takes me to that picture in which I show you one of the reasons why we don't see that much prevention in psychiatry is because it takes a long time. This is another good example. This is a high scope preschool study. All these children were followed up until the age of 40. So they were followed up for 35 years. And what you can see here is that comparing those who received the program versus those who did not receive the program, there were drastic differences in very, again, hard outcomes, like homework at age 15, IQ 90 or plus at age 5, 67% compared to 28%. Arrested 5 times or more by time 40, 55% in those without intervention as compared to 36%, again, in this especially vulnerable population. Primary school, child abuse. And child abuse is one of those risk factors that increases any type of mental disorder, depressive disorders, post-traumatic anxiety, alcohol abuse, drug use disorders by 2 times, 2.5, and you mentioned it. Can we prevent child abuse? Yes, we can. We can. And again, this is a meta-analysis showing that by parent training programs that are, again, are very cost effective, we can reduce child abuse. And by reducing child abuse, we will improve the quality of life and the mental health of these children for their entire lives. This is a nice study about causality. So, and again, focusing on psychotic symptoms. So we know that roughly around 8% of 8-year-old kids have auditory hallucinations. And this is in the blue line. If you are physically abused or you suffer bullying, then it's not 8% anymore or 5% or whatever. Then it goes up to close to 20%. So you multiply by 3 the number of children that suffer auditory hallucinations. If you stop the physical abuse, then the percentage of children that experience auditory hallucinations go back to normal levels, right? And the same for bullying. If you do that too late, when they have been a physical abuse for a long period of time, that reduction does not take place. And that, again, is maybe one of the reasons why they become chronic, and then they end up with a diagnosis of schizophrenia or psychotic disorder. Not only that, but some of these risk factors increase the risk of another risk factors. For instance, if you have a low IQ, if you have autism, if you have a bad theory of mind, you are more likely to be abused or bullied. If you're bullied, you'll have an increased risk to have another mental disorder. So again, this is why we became interested, as I mentioned to you before, in all these studies, in clinical trials, in trying to reduce risk factors in the school. Adolescents. So this is a study we did EUGI in many European countries. This is the prevalence of cannabis use in many European cities, and you can see here is a nice parallel lines between how much cannabis, especially potent cannabis, is smoked in the cities, and what is the incidence of psychosis in those cities. And this is a nice study by Marta Di Forti published last year in Lancet Psychiatry. Can we prevent cannabis use in adolescents? Yes, we can. And again, this is a meta-analysis, many studies out there. We should do it in very high-risk populations, like those that are, offsprings of patients with people with mental disorder, those with 22q11, and so on. So to finalize, I will move into the third point, implications. So how has this changed my life? And, I've been asked by the organizers also to give you some personal notes. What took me to move into primary prevention in my research life? I like to be pragmatic, and I like to spend my time in things that are worthwhile and in areas of psychiatry that may benefit the most. And again, that's why I decided to put my interest in my clinical practice in children, adolescents, and in the prevention area. This is again the study we have just finished, and I can share with you very preliminary unpublished results in which we studied around 4,000 children and adolescents. Half of them were in schools that were randomized to have a preventative program. So this was a program based on respect to diversity. All the schools have children with special educational needs. All the schools have children with regular education, but also some kids that have mental problems, autism, and so on. They were all regular schools. And I can share with you that we managed to reduce significantly the number of kids, including kids with special educational needs that had episodes of abuse during the school year. This is Porpoise, another European trial with omega-3 fatty acids versus placebo to prevent transition into psychosis that we are part of. This is probably secondary prevention study, patients that already have had a first psychotic episode. These are all adolescents. We give them 3 grams of N-acetylcysteine or placebo. N-acetylcysteine is the precursor of glutathione, the largest antioxidant in the brain. And the primary outcome here is loss of frontal gray matter. So the hypothesis here is that we're able to prevent loss of frontal gray matter in those who receive N-acetylcysteine as compared to placebo. We need to incorporate all the evidence out there, and many of the evidence on risk factors is genetic evidence, right? So we need to develop programs that focus on these children that have specific conditions, Phelan-McDermid, Down syndrome, DiGeorge syndrome, 22q11, Angelman's, you name it, right? That are very likely to develop psychiatric conditions. And we need to start them as the pediatricians do with the normal kids, right? We need to start to see them in standardized visits before they show those mental disorders. There are many interventions for these kids that have shown to be efficacious. So what are we waiting for, right? What are we waiting for to intervene with these risk groups for schizophrenia or the mental disorders? I don't have any answer. The answer is that if we have not done it yet, and I know that in many Northern European countries, like countries like Denmark, and even in countries like the UK, it's a paradigm that is changed because they are more able to follow the evidence. And again, this is not the case in many other countries. Actually, in the Spanish Mental Health Network with Jose Mariano, we had the opportunity to coordinate the framework for the European mental health research priorities, right? The roadmap for the European Union priorities for mental health research. And number 1 was research into mental disorder prevention, mental health promotion, and interventions in children, adolescents, and young people. And that was what we told the European Union, right, for the Horizon 2020. This is where you should put your emphasis and prioritization in terms of mental health research. For those of you who are interested in this area, this is a paper we published last year in Lancet Psychiatry, in which we have these therapeutic windows with during life with specific examples of what should be done in each one of those periods. We have also at the ECMP, and I'm the past president for ECMP. We have a really nice group on prevention and mental disorders and mental health promotion. This is a paper that we published last year, 2019, on the activities that we do within this network. So to finalize, my conclusions would be that there's still little research in preventative interventions for mental health. Risk factors don't seem to be disorder specific, and that's the case for psychosis, schizophrenia, and other mental conditions. A priority for the next few years should be the focus on very early interventions in specific periods of time where those interventions are most cost effective. And in those at very increased risk, we should do at least narrow monitoring, parent training, and training coping skills in all cases. And with that, I would like to thank you for your attention. I'm very optimistic. And I think that I believe there's a lot of light at the end of the tunnel for the COVID-19. There is a lot of light for what we need to do in terms of prevention and psychiatry. Thank you very much for your attention.